My name is Wasim. I'm a second year fellow. This is a very interesting topic that I'm going to present, simultaneous liver kidney transplant. And before doing the presentation, I didn't know how controversial this topic is. But then it became more of a challenge rather than anything else. So just a little bit overview about liver transplants and the liver kidney transplant. About 20% of our patients going for a liver transplant, they have acute or chronic kidney injury. Only 2 of these liver transplant patients are deemed candidate for a renal transplant. Since the introduction of MELD in USA since 2002 as a sole criteria for liver donor allocation, there has been a subsequent rapid increase in liver kidney transplants. And in up to one speculations, it has gone up to as high as 300%. So if you look at the current UNOS data for liver kidney transplants or the liver transplants, we see that around 2002, which is right over here, since the introduction of MELD, we were doing it around 100 liver kidney transplants at that time. Since the introduction of MELD in 2002, there has been a rapid increase in liver kidney transplants in 2006. And as you can see the data here, previously we were doing it at around 100 in 2002. Since after the introduction at MELD, since 2006, we are doing it around 350, 360 combined liver kidney transplants. Just a data to show the liver transplant recipients. And again, this data is showing that since 2001-2, when the MELD criteria was introduced, we have got a sudden bump of liver transplants. So what is MELD? MELD equation, basically it's a scoring that was implemented to help delegate liver to recipients who are at greatest need for these liver transplants, and the aim was to reduce death when they are in waiting list. So this was basically a allocating tool that we are using. It helps predict the mortality. And if you look at the MELD equation, serum creatinine over here, as you can see, serum creatinine does play a major role in determining the MELD score. So if you look at the MELD scoring, there are 4 levels: greater than 25, 19 to 24, 11 to 18, and less than 10. The lowest number is 6, and the cap is at 40. So you cannot have a MELD score below 6, and you cannot have a MELD score below above 40. Usually the patients are put in on the list when their score is around 10, and they are brought in for a transplant when the score is around 15. So let's talk about the controversies or dilemma related to liver kidney transplant. The biggest one is to how to determine the recovery of acute kidney injury in the setting of any stage liver disease, and this is really challenging. How shall we determine what is the net benefit of kidney transplant in liver transplant in liver candidates with kidney failure? Again, we don't know whether they will recover from their acute kidney injury or not, and that is the basic hurdle. And number 3, what is the discrepancy between the liver transplant alone versus a liver kidney transplant with a high MELD score, suggesting that the liver kidney transplant with any stage renal disease have less severe liver disease than the liver transplant alone, and these patients may actually be receiving liver transplant prematurely. What I mean to say over here is that the patients who have got any stage renal disease obviously have got a high serum creatinine, and once they have got a high serum creatinine, their MELD score will automatically go up. And basically it is not their liver disease that is determining the MELD score, then it would be their renal problem or the ESRD that will be determining a high MELD score. And for these patients, are the liver transplant really justified or not? So let's talk about this first. What is the disparity in recovery for acute kidney injury in waitlisted candidates, and level of kidney dysfunction in liver kidney transplant versus just the renal transplant recipients? So in order to do that, we have to review all the data that was presented in 2006 annual report on liver kidney transplant. By the way, this 2006 OPTN SRTR annual report, basically it was a conference that was held in 2006. You have all the surgeons, the transplant nephrologists, the transplant surgeons, and the American Society of Nephrology people, all of them came in together and they reviewed the data from pre-MELD to post-MELD. So pre-2001 to up till MELD at 2002 to 2002 to 2006. So let me tell you about this data a little bit. So as I stated before, introduction of MELD 2001 2002, you can see there was exponential rise of liver kidney transplant, as you can see here, and you can see here in the blue light blue bars that your liver kidney transplant did rose up, and to some extent your liver transplants also exponentially rose. If you look at the wait list for the registrants for combined liver kidney transplant by 2006, you have around 9,000 people who are waiting for a combined or simultaneous liver kidney transplant, versus around 13,000 people for just the liver transplant in 2006. Unadjusted death rates for people who were on a liver transplant wait list was around 120, 130 cutoff. And this is the waiting list for more than 90 days for 11 major regions in America. The number of living donor recipients also did rose after the MELD era, that is 2001 2002, as you can see here. Oops, sorry. The mean MELD scores at the time when they were doing the transplants is shown here, and is around 20. And this is the data to show the simultaneous liver kidney transplant over time. So around 100 in 1999 went up to around 400, 450 in 2006, 2007 area. So the data that the 2006 OPTN SRTR conference had included, obviously it was a UNOS SRTR data. The data was reviewed from February 2002 up till December 2005. Only first listing of the candidate during this study period was included, irrespective of their previous transplant history. The actual date of dialysis pre-transplant was not known. Patient considered to be on dialysis if the hemodialysis was performed twice a week prior to transplant, and that's a big bummer. Time of waitlisting for liver kidney transplant candidates was considered to be the most recent for either the liver or the kidney listing dates, and this is a little bit controversial as well. So the analysis include 27,343 liver transplants candidates who were not on dialysis at the time of listing, and it include 577 liver transplant on dialysis at listing. 605 patients had liver kidney transplant not on dialysis at listing, and 579 liver kidney transplant on dialysis at listing. So this is the number of patient population that was reviewed. The average MELD score is shown here in this slide, and as you can see that the MELD score was high on people with dialysis. So you can see here and here, those are the people who are on dialysis, and obviously end-stage renal disease, the creatinine would be high, and therefore the MELD score would be high. This is a very interesting slide. It shows the dialysis status on various different population that were studied in this review. And what they found out was that around 15% of these patients listed for liver transplant and known discontinued dialysis at the time of their transplant. So 15% of the patients listed for liver transplants actually discontinued their dialysis at the time of their liver transplant. And for SLK or simultaneous liver kidney transplant, around 6.5% of patients listed for simultaneous liver kidney transplant discontinued dialysis at the time of their transplant. And if we review the data for our ESRD patient on dialysis, we know that around 4.3% patient at that particular time listed for a renal transplant discontinued their dialysis at the time when actually they got the renal transplant. So there is a difference. Like, even if it's a 6.5% difference, that means that these patients either have recovered from their kidney disease or something happened. 6.5% is little higher than 4.3%, and definitely 15 is a too big of a figure for the patients who discontinued their dialysis. That means that their kidney functions did improve. So what they found out that 7% of the patients listed for simultaneous liver kidney transplant actually got a liver transplant instead. So, and that indicate that either their kidney function improved, or it may denote that they only accepted the liver transplant because of either a poor kidney donor quality, or there have been concerns about kidney viability in an unstable liver candidate. So the overall data showed that the liver transplant candidate experienced both reversible and progressive renal failure, renal dysfunction. So what they're trying to say to us is that we cannot tell for sure whether these patients actually had their kidney functions improve or their kidney functions got deteriorated. We don't know. If you look at the waitlist mortality, if you can see over here in this paragraph, the liver transplant people on dialysis, they had a very high short-term mortality, as you can see in the diagram over here, in the figure over here. They have a very high short-term mortality, but if you look at their long-term mortality, it actually equals with patients who had liver transplants who were not on dialysis. That is like after more than 3 years. This diagram also shows us that the liver kidney transplant have better short-term survival if compared to liver transplant patients on dialysis. So your 30-day survival was 74% for simultaneous liver kidney transplants versus 63% for liver transplants on dialysis, and the 1 year survival was around 51% versus 31% for liver transplant on dialysis. If we look at the survival based on serum creatinine for patients who just receive or only receive liver transplant, no brainer, if you have got a better renal function, your survival is more. If your kidney function is bad or worse, your survival is bad. And you can see in number 5, line number 5 is patients with hemodialysis, they did worse. But interestingly, when we look at the data for simultaneous liver kidney transplant, there was something strange here. Here what this diagram is showing that the patients who had better renal function did worse on the wait list. So you can see the diagram over here, number 1, which is serum creatinine less than 1, obviously no hemodialysis, they did worse. Number 2 over here in gray, in black, they did worse other than the other group. So what this diagram is saying to us is that the waitlist candidates or waitlist patients who were on the waitlist for liver kidney transplant, simultaneous liver kidney transplant, they did worse in terms of kidney function. If their kidney function or serum creatinine was low, they did worse. And this is a waitlist data. What about the post-transplant data? And the post-transplant data is actually the same. It also tells us that even if these patients receive their kidney transplant, liver kidney transplant, even the post-survival data based on their serum creatinine was worse if you have got a reduced or if you have got a better kidney function. As you can see, line number 1 and 2 here, with a serum creatinine of 1 to less than 1.5, no hemodialysis. Line 2 is serum creatinine 1.5 to less than 2, no hemodialysis. These patients actually did worse. Their short-term mortality was worse than people who have got a higher serum creatinine. Now, what does this tell us? If we look at both the graphs together, this tells us that the majority of mortality difference was accounted for by the liver disease severity. So what they are trying to tell us is that in these patients, they have actually a worse liver disease. And what they figure out that through statistical analysis, what they found out that in these particular patient population or patient group, if you increase their MELD score by 1, there was a 17% increase in mortality risk. What is not shown in this figure is that the 2-year survival for simultaneous liver kidney transplant patients on dialysis was actually lower than liver transplant candidates on dialysis. And the data was 71% versus 76%. I don't know what the reasons are. Maybe there was some selection bias. Maybe there were some confounding or insufficient data related to it. But having said that, the data is very controversial. The data was confusing. So finally, they tried to look on for the renal outcomes after liver transplant versus simultaneous liver kidney transplant. And the best measure or the best way to look for a renal function in these patients is to see whether how many of these patients actually required a renal transplant after after a liver transplant or a combined liver kidney transplant. So the table below is showing that for the patients who were listed for kidney transplant within 1 year of either a liver transplant, which is here, or for a liver transplant or for a combined liver kidney transplant on dialysis, of total of 38 patients. So where's the pointer? So 25,616. So of a total 38 patients listed for kidney transplant, only 12 were on dialysis. So here and here, only 12 were on dialysis. And if you look at long-term post-transplant, only 2 of these 6 listed for dialysis actually were on dialysis at the time 1 year after transplant. And this is the data for liver transplant only. For patients who were on simultaneous or who had both liver kidney transplant, who were on dialysis at the time for transplant, they did not even require dialysis 1 year afterwards. The next table is showing 53 patients here who were actually listed for simultaneous liver kidney transplant, only received liver transplant. Of those, only 1 patient was listed for a kidney transplant 1 year afterwards, and 2 patients actually got a kidney transplant. So for them, their kidney function got worse. Either they were too sick to receive both the liver and kidney at the same time. I'm not sure about that. So if we summarize the renal outcome after liver transplant or simultaneous liver transplant, we can easily say that the renal dysfunction in a graded fashion negatively impacts your pre and post-transplant, liver transplant outcomes. We can also say that pre-transplant renal dysfunction may be reversible or it may progress. We can also conclude that the liver disease severity appears to be more pronounced in waitlist simultaneous liver kidney transplant patients or candidates than liver transplant patients on dialysis. And we can also say that for candidates on dialysis at the time of transplant, liver kidney transplant survival, which is a short-term survival, is superior to liver transplant alone. However, this is not true with a lesser degree of renal function. Within an year after transplant, only a small percentage of liver transplant patient will need renal transplant. So if you look at all this data summary, you will be thinking, what is he trying to say? Well, at this time, I really don't know. This data is really confusing. So because the data is so confusing, there was a need to evaluate these liver transplant patients for renal failure. We need to determine whether these kidney function or the kidney dysfunction is either acute, chronic, or whether these patients will actually progress towards end-stage renal disease. So what they were suggesting was that if the patient who is a candidate for liver transplant has already got to a point where he is needing dialysis long run, or he is actually on dialysis, evaluation for a simultaneous liver kidney transplant should proceed according to the institutional protocols. For patients who have either chronic kidney disease or acute kidney injury, there was a logarithm that was generated. We will see that logarithm later on. What they were suggesting was that the serum creatinine is really unreliable. It will not tell you, number one, the degree of kidney disease in this patient, and number two, whether this patient will progress to whether this patient will have a progression of his or her CKD. What they were also suggesting is that if their serum creatinine is near or above normal value of normal, a thorough renal evaluation should be done, and there should be an aim or effort to determine and differentiate between an acute reversible kidney disease versus fixed anatomical disease. And this is the algorithm that they generated, basically telling us that there has to be a thorough investigation to determine whether this patient has a CKD, whether this patient has this patient has got a CKD. So just to summarize the data, so analysis of the data of this consensus group, what they were saying is that the kidney transplant is not commonly needed within the first year of liver transplant, and the dialysis requirement alone prior to transplant does not reliably predict the need for future kidney transplant. Analysis did not account on confounders, for example, hypertension, diabetes that can affect renal function. They were also saying that renal function in a graded fashion negatively impact pre and post liver transplant outcomes. And pre-transplant renal failure may be reversible or it may progress. What we also have discussed is that the liver disease severity appears to be more pronounced in simultaneous liver kidney transplant waitlist patients than for the waitlist patient on liver transplant candidates on dialysis. For candidates on dialysis at the time of transplant, simultaneous liver kidney transplant short-term survival is superior to liver transplant alone. And within an year of transplant, only a small percentage of liver transplant alone may need a renal transplant. So, reviewing all this data, there have been a lot of questions that can come. The question arises, is this simultaneous liver kidney transplant really necessary? Are we unnecessarily reducing the kidney donor pool, which can actually benefit our ESRD patient? Because, you know, if we are unnecessarily doing a simultaneous liver kidney transplant, then obviously we are taking donor kidney pools for ESRD patients. And we know that around 6% of our ESRD patient on waitlist die waiting for a kidney transplant. And the biggest question is, what should be the indication and or what should be the net benefit of having a simultaneous liver kidney transplant? So, to answer these questions, they met in again after an year and a half. This was a second consensus meeting that they had. This consensus meeting had people from ASTS, or American Society of Transplant Surgery, American Society of Transplants, UNOS, and American Society of Nephrology. Everyone came in together to have a second consensus conference just on simultaneous liver kidney transplants. They reviewed the SRTR data from the start to MELD system, so from 2002 to 2007, and their aim was to propose indication for simultaneous liver kidney transplant, and they wanted to establish a prospective data registry, and they want to recommend some standard listing criteria. So the data that they had, when they analyzed that data, they found out that 7% of all the liver transplant candidates were either on hemodialysis, listed for combined liver kidney transplant, or they were on both. Of all the liver transplant recipients who actually got liver transplants, 8.2% were only on hemodialysis at the time of transplant, and 6.1% actually received liver kidney transplant. For the patients who had simultaneous liver kidney, or the candidates for the simultaneous liver kidney, they found out that 50% or half of them had both liver kidney listing, 36% had liver followed by kidney listing, and 7% had kidney followed by liver listing. It was very interesting to see this. You know, we thought that, or when I was reviewing this simultaneous liver kidney transplant, I thought that the major indication for doing a liver kidney transplant would be a hepatorenal syndrome, but in fact AKI or hepatorenal syndrome was only indicated in 2%, or only 2% of patients had AKI or hepatorenal syndrome. Most of these patients, we did not even had a diagnosis for them. Unfortunately, the true prevalence of end-stage liver disease and these candidates were unknown. So among the liver transplant candidates on dialysis at listing, they found out that 67 of 428 candidates were not on dialysis. Among the candidates for combined liver kidney transplant, they noted that 41 of 634 listed were actually on dialysis at the time of listing. 41 of 434 were on dialysis at the time of listing, were not on dialysis at the time of listing. And 509 out of 688 patients not on dialysis remained not on dialysis at the time of transplant. The various MELD scores at listing and at the time of transplant is shown here. And this is a very interesting graph. What this graph is telling us is the patient survival on the waitlist and post-transplant survival. And on the waitlist survival, it is showing that the liver kidney transplant waitlist have increased mortality. As you can see over here, this is liver kidney transplant on dialysis. These patients have got more or short-term mortality. Liver kidney transplant on dialysis have short-term mortality, but if you compare it with this group of people, which is liver transplant not on dialysis, their long-term mortality or their long-term survival is actually the same if you go beyond 3 years. For the post-transplant survival, what they are saying is that, and I want you to see these two lines over here. This is liver kidney transplant on dialysis and not on dialysis, and this is liver transplant on dialysis. What it is showing is that liver kidney transplant candidates on or not on dialysis have better short-term survival versus liver transplant on dialysis, but decreased survival long-term compared to liver transplant on dialysis. So what they are trying to say to us is that even though if you do a combined or simultaneous liver kidney transplant, the short-term survival is there, but long-term survival is, there is no benefit for the long-term survival. In this study, what they were saying is 76% survival for liver kidney transplant versus 71% survival for liver transplant on dialysis. So technically the same. Another very interesting graph. What this graph is showing is kidney after liver transplant. So you have got a liver transplant, then their kidney function is not recovering or is getting worse, and then you do a kidney transplant. So I want you guys to forget this line. This is a living donor kidney. In real world, we have got a deceased donor. So this deceased donor is right around here. Deceased donor is right around here. And this is your simultaneous liver kidney transplant. What they are saying is that there is an increased survival benefit with kidney after liver versus liver kidney transplant together. But if you look at the long-term benefit, there is none. So 63.7 versus 64 in I think this is 60 or 80 months. So 2007 consensus conference gave us recommendations, and the recommendations were that their evaluation should be the same as what was published in the first consensus conference. So by that I mean the algorithm that I showed you earlier. What they also recommended was that the prospective candidates, so the prospective liver kidney transplant candidates, should be categorized into acute kidney injury and CKD based on definitions of National Kidney Foundation guidelines. So rise in serum creatinine for greater than 90 days. Once on waitlist, kidney function should be assessed when confirming the MELD status. They were saying that if you do a biopsy, if there is an intrarenal fibrosis, it is a marker for progression of ESRD, and therefore greater than 30% interstitial fibrosis. If present in a liver transplant candidate, he or she should be a candidate for a combined liver kidney transplant. What they were saying is that glomerulosclerosis of greater than 30% is basically the same. So glomerulosclerosis of greater than 30% is also a marker of CKD and should be used as a criteria for listing for a combined liver kidney transplant. If your GFR is less than 30 with chronic course, they should be evaluated with a biopsy. Renal biopsy in liver transplant only candidates should be timely enough to help making a decision for simultaneous liver kidney transplant. What they were saying is try to do a biopsy early rather than doing it late or not doing it. If the biopsy is not possible, then the decision for kidney transplant should be based on using NKF criteria for CKD. Key is to, and this is very important, key is to distinguish between AKI and CKD. A MAC3 should be used 3 to 6 months after a liver kidney transplant along with the GFR to determine function of native and the transplant kidney. Just to show the logarithm. So while we have discussed that, what about the patients who have got cirrhosis and they have got an end-stage renal disease? Unfortunately, the data is there is no much data on these type of patients. What they are saying is that patients with asymptomatic liver disease, usually child's A cirrhosis or stage 1 or early stage 2 cirrhosis, they usually do well with kidney transplant. They do not usually need a liver transplant anyway, and they are very good to go for a kidney transplant. What is important to know here is that 10 to 40% of these patients who have got liver cirrhosis of any kind have got HCV with a MELD score of around 21 with normal bilirubin and INR. So here comes the HCV part, which really confuses things up, because HCV, if this is a virus, if you give them transplant, then you are immunocompromising them, and that can technically increase your viral replication and so on and so forth. So now we need to determine the data for the hepatitis C virus, and whether these patient needs a liver transplant or these patient needs both a liver kidney transplant. So recently, not long ago, they have done a study on hepatitis C virus infection in the kidney transplant. So these are the patients who got a kidney transplant and they have a hepatitis C infection, and they looked at the patient survival and graft survival. So interestingly, in this graph here, this line is showing a non-hepatocellular virus. So these patients have got kidney transplant and they do not have a HCV, and these patients have got HCV. And obviously your patient survival was low or reduced with patients who have got HCV infection going on. And usually it is more for patients who have got a stage 3 and stage 4 fibrosis. And if you look at the graft survival of the kidney graft survival, no-brainer, the patients with hepatitis C infection have got a reduced graft survival long run as compared to patients who do not have the HCV. But this graph was really interesting. Now what this graph is showing us, and this was the same study, what this graph is showing us, now you have got 3 patient population or 3 patient group. The black line on the top is showing the patients who have got kidney transplant who do not have hepatocellular or HCV infection. This was the second line is the patient who have HCV and who had the kidney transplant, and these are the patients who have got HCV and they were on they continued dialysis. And what they figure out that patient do good if you give them a kidney rather than if you continue to stay them on dialysis. On dialysis, their overall survival reduces down significantly in 3 years. So what is the real effect of hepatitis C induced liver fibrosis on survival in kidney transplant patient? And the answer came out as none, just to confuse things up more. So this study was done on 58 patients with HCV infection on hemodialysis undergoing kidney transplant. And if you look at the dark black line over here, this is no fibrosis, dotted line is advanced fibrosis, and you can see the fraction surviving is the same. So what they were suggesting was that the mortality is not related to the degree of liver disease, but rather than the presence of other comorbidities or confounders, meaningly diabetes and advanced age. And what they said again was that if you've got a child A cirrhosis, this can be treated asymptomatically. This can be treated and the patient can remain asymptomatically, and they can be served well with kidney transplant alone, not the liver transplant or not the liver kidney transplant together. So the logarithm what they generated for ESRD patient with liver disease is this, and this basically guide us whether to do a simultaneous liver kidney transplant in these patients or just to go for a kidney transplant. So now that we know what is the data for these patients who have got the end-stage liver disease and who have got hepatocellular C carcinoma, what about patients who have got advanced age? And then the next question comes in, do we need to do just the liver transplant or do they need both liver and kidney transplant? So the data with age is very interesting. Usually what we know about is that people who have got who are elderly, they do well, and age is not a risk factor for kidney transplant. Over here, what this graphs are showing us is that elderly recipients have significant increased risk for poor graft function, but their overall survival stays the same, and this is true. Do I need to do anything? And this remains true. So if you look at the patients with who are more than 65 years of age, and whose donors or whose donors are less than 65 of age is C, and if you compare it with the recipients who are less than 65 years of age with a donor of less than 65, which is A. So I want to look at the lines A and C. And in the first graph here, you can see that the young people have got better survival than the older people, have got a poor graft survival than the older people more than 65 years of age. So I want you to compare at lines A and C. So A is younger people less than 65 years of age with a donor of less than 65 years, and C is older recipients who are more than 65 years of age with a donor less than 65. Their graft survival is low. As you can see the difference here, their graft survival is low. But if you look at the overall survival, their overall survival is technically the same. This graph here is actually showing you the waitlist patients, the transplanted patients with a donor less than 65, which is line B, and transplanted patients with donors of greater than 65 years of age. And what this graph is saying to us is that as compared to patients with ESRD, on waitlist, on hemodialysis, the kidney transplant in elderly patients with donor greater than 65 years does not offer survival benefit in 80 months. And people on dialysis who have got kidney transplant, and I'm sorry you cannot see it properly, but the bottom two lines with dotted and which are dash over here, these are for this line is for patient who are more than 65 years of age and have got a liver transplant only, and the dash line below is more than 65 years of age with both on dialysis on both liver and kidney transplant. Their survival is low as compared to younger people. And I'm sorry, this is a UNOS data for 20,196 patients. So now we know that with advanced age, more than 65 years of age, for transplant recipients, life expectancy benefit for kidney transplant over patients on hemodialysis is lost when they close 70 years, and the same is true for liver transplant recipients as well. So the recommendations, what they were saying is that the mortality is increased in older patients greater than 65 years of age. Their hazard ratio goes up to 1.36 compared to patients less than 65 years of age on dialysis. And for patients with liver transplants and simultaneous liver kidney transplant, their hazard rates also is very high. What they were suggesting is that based on the above unfavorable outcome for older patients on hemodialysis, and mind you, this data is for patients on the hemodialysis. So it is very recommended that careful consideration should be made while selecting these patients for simultaneous liver kidney transplant. The second thing that always we think about is, if the data is so conflicting, shall we just do the liver transplant, or do they still need the simultaneous liver kidney transplant? And if you look at the same graph here, we know that as compared to liver transplant on dialysis, the patients who receive both simultaneous liver kidney transplant, they've got better short-term outcome in terms of mortality, as you can see over here. We also know that there has been studies done that have found out that the duration of pre-liver transplant renal dysfunction may actually predict your post-transplant renal function, and this was the study that actually tell us that. What they were saying is that if you have got a renal dysfunction for more than 12 weeks, which is the dotted line here. And if you've got renal dysfunction which is less than 12 weeks, meaning the need of hemodialysis, what they were saying is that only 13% had a GFR of more than 20, 36 months post-transplant after adjusting age and serum creatinine in the time of transplant. This study looked at the outcomes in liver kidney transplant recipients with and without hepatorenal syndrome and on dialysis pre-transplant, and the dialysis requirement was more than 30 days pre-transplant. It also had a cohort of 148 patients with liver transplant who had hepatorenal syndrome at the time of liver transplant. And I want you guys to have a look at the 1 year patient survival. So the 1 year patient survival was essentially the same for patients who received liver transplant alone and who were on hemodialysis less than 30 years, as compared to patients who got both the liver kidney transplant and they were on hemodialysis less than 8 weeks. But interestingly, for patients who were requiring long-term hemodialysis before their simultaneous liver kidney transplant, their outcome improved. And it is also showing that the need for hemodialysis reduced significantly in hepatorenal syndrome post liver transplant. So the question really is whether is there a need for simultaneous liver kidney transplant in these patients, or whether we shall be okay with just doing a liver transplant. So the questions come in, when to do a simultaneous liver kidney transplant, who will actually get benefit with liver kidney transplant, and what would be the net benefit for simultaneous liver kidney transplants. So the recommendation, and this is what we are working right now in various big centers in America, and what the recommendation guidelines is for patients who are not on hemodialysis or who are not on dialysis. If their GFR is less than 30, and if the criteria for if they are meeting the criteria for CKD as defined by NKF, they should get a simultaneous liver kidney transplant. If their GFR is greater than 30 and they have got CKD, they should be getting only liver transplants, but they should be carefully educated, and they should be educated for the possibility of kidney after liver transplant. For patients with AKI, hepatorenal syndrome, liver kidney transplant should not be considered. The reason why there is no beneficiary data as compared to liver transplant alone, there has been a lot of potential that this AKI will get improved after liver transplants, and there is a very low likelihood of progression of CKD in early years post-transplant, as what I've shown you in all the data in previous slides. For patients on dialysis, liver kidney transplant is recommended on patients with on dialysis. For end-stage liver disease in setting of AKI requiring dialysis, liver kidney transplant should be tentatively considered or very carefully considered for patients requiring dialysis for more than 8 weeks, and their serum creatinine should be more than 2. For patients with glomerulosclerosis, they should be considered for simultaneous liver kidney transplant if their kidney biopsy is showing greater than 30% glomerulosclerosis or interstitial fibrosis. The last question, what is the net benefit? We don't know. It's still unknown. There has been a lot of debate going on. And basically the debate is centering around the discussion that when we are giving, there has been a number of liver candidates whose life we are saying with doing the kidney biopsies, but technically we are removing the donor kidney poles from patients who can actually get any stage, who actually can get a kidney transplant. We know that very fewer lives are being saved with liver kidney transplant than having liver transplant alone. We also know that number of people subsequently requiring liver transplant after liver kidney transplant after kidney transplant, thus receiving a net benefit, remains unknown. And then we also know that the incidence of acute rejection and or kidney graft loss is greater in kidney after liver transplant. And we know that 6% of ESRD patients on waitlist for kidney transplant actually die on waiting list, waiting for a kidney transplant. And with this, I end up and open up myself for questions.